the friendship and the partnership over the years. And of course, to everyone here as part of the BioUtah family, again, really appreciate the chance over the years to engage with you. It's very much appreciated. As I've told Michelle, it's a little bit like a Christmas carol. I am the ghost of CDRH past. So the person you really want to hear from is the ghost of CDRH yet to come, and that's Michelle Tarver. So I'm going to hand it over to her for some remarks, and then we'll open it up for questions.
Well, thank you, Jeff, for passing it off to me, and thank you, Kelvin, for the warm invitation. I just wanted to spend a couple of moments just acknowledging what a wonderful mentor leader that Jeff Shuren has been at CDRH, not just for myself, but for many people that walk the halls of our center. Really, he has transformed how we do business, and he has transformed how we conceptualize and incorporate voices that often aren't included at the table, which are our patients' voices. And so I would love to applaud him for that work. As I step into the role, obviously, I know that I have really big shoes to fill, and I often say I've opted for a different pair of shoes. I'm putting on some high heels instead. So that'll be my approach. I thought I'd spend a couple times just telling you a little bit about myself. I am not new to FDA, although I am new to this role. I've been at FDA for over 15 years. And I come from a long line of people who have served this nation in many different ways. So the concept of service is really part of my DNA. I also want to stress the importance of patients. I think that you have seen it in our mission and vision statements, and it's been a part of my role in many ways over the course of my time at CDRH, really making sure that we do what we can to bring their perspectives, their insights to bear in the products that we regulate. And not only in the products we regulate, but also in how we do our daily business, because patients lend insights to all of us individually that help us better understand why we do the hard work that we do. The last thing that I want to emphasize is my focus on collaboration. I don't believe that any solution is crafted by one mind, one perspective alone. It really is by linking hands across the entire ecosystem that we tailor solutions that meets the needs of the people that we are ultimately trying to serve. And so I have done a lot of work over the years in terms of forming collaborations, not only with patient groups, but also with professional organizations, industry collaborators through our collaborative community work. That really has moved the needle in a number of different areas where folks are tackling those tough challenges together, forming and having those difficult conversations, and then crafting solutions that really can be implemented and adopted in a way that has lasting impacts. That is really kind of the approach that we have found works best, and is really the approach that I plan to continue while I sit in this seat. And the last thing that I want to mention before turning it back to you, Kelvin, is the importance of continuous improvement. There's a saying that if you stand still, you fall behind. And so we are always looking and reflecting on all the things that we've done, the great accomplishments we've already done on the two pillars of innovation and safety, and how can we continue to build as we move forward on those two pillars. So I will stop there and turn it back to you and welcome questions from the audience.
Thank you, Jeff and Michelle. We appreciate those comments. I will make a comment on continuous improvement. That is a hallmark of many medical device companies, and having been in the industry a long time, my wife has even adopted that and says, I need to do that same thing in our marriage. So it's a great principle to apply in business and personal. We'll invite questions from the audience, and while we're waiting for people to line up at the microphones, I'd like to just ask a couple of questions to kick this off. So Jeff, as you reflect on your service over the last 15 years or longer, what have been some of the most significant accomplishments or challenges as you reflect back?
Well, one of them is I got to meet, work with, and I think help support and promote Michelle Tarver. That's top on my list. She is the right person to lead the center. I'm very, very excited that she's in there permanently. Some of the things I'm most proud of, first of all, I'm very proud of where we've gone as a center, the culture. that we have adopted over time that I think really drives the work that we do, as Michelle said, on our two pillars of safety and innovation. Another big hallmark is our focus on patients. When I came in, it was an effort to get a focus back on public health, which I agreed with, but patients was not part of the lexicon. And we try to make very clear improving the health and the quality of life of patients, people, is what we are about through the work that we do. And that has been front and center with the vision that we set. It's been in setting up a patient engagement program. None existed 15 years ago. And when we started, it was one person. And eventually I said, I could put the whole team in the trunk of my car and drive it around. But today it's a vibrant program, and Michelle is one of the architects for where we've arrived. It's really made a difference. Lastly, I mentioned the state of affairs here. When I kind of came in, all the great innovations went everywhere else but the U.S. first, and sometimes never came here. As a clinician, as a patient, could really see the negative impact on people's lives. When there are technologies that can make a meaningful difference to people, it's our obligation to help, if they're safe and effective, to get timely access to people and really to all people. And that's the effort we've tried to make over the past few years. And I think we've turned that around. And now a lot of the great innovations are coming here, first or in parallel with other markets. The next initiatives, and again, Michelle, big architect here, is, we can get them to the U.S., but if we don't get them in the hands of the people who need them, then our job is not done.
I really appreciate that response, especially the focus on having companies bring devices, drugs, everything to the United States first. I think that's a great objective. So one other question before we go to our audience. Michelle, based on the foundation that's been laid by Dr. Shuren or by Jeff and others, where do you see the agency going under your direction? You've mentioned a few of your general objectives. Are there specific programming elements that you're looking at building on this foundation?
Absolutely. There are, you probably have heard us talk a little bit about home as a healthcare hub. And it is an initiative that was born out of the reality that we're currently facing and where we're going to be facing in upcoming years, where we've got explosion of chronic health disease, we've got contraction of life expectancy, we have a healthcare provider network that is dwindling each day and not being replenished at the same rate. And then we have contraction and closure of healthcare facilities, hospitals, where people are seeking care. And so the distance, both physical and time and person distance between the person who needs the healthcare and the provider is getting wider. And the way that we have to reimagine healthcare is not focusing just on the systems that provide care, but instead focusing on the people who need the care and finding ways to bring that care closer or into those homes. Our initiative is keeping that home in mind. What does the home look like? And then how can technology nestle into the home in a way that it's seamless, that it's intuitive, that there's not a lot of friction in terms of people getting the information they need that can impact their healthcare outcomes. And then it can integrate with the healthcare providers so that it buys them bandwidth so they can spend time focusing on the things that are most important to a provider. I see patients still in clinic. I see about 30 patients in a morning. If I can move some of those assessments out of my clinic, that I can spend time actually talking to people, getting to know them, and tailoring solutions and treatments that meet their needs specifically and fit into their lives, that's how you have true wins, and that's how you have true impacts on healthcare outcomes. So our work is really focused on how can we create an environment that will, one, inspire innovative technologies to meet those needs, as well as, secondly, how do we create an approach, a framework that facilitates not only the development of those devices, but also the incorporation of those devices into care paradigms and payment for those solutions too.
Great, thank you. Home healthcare is certainly on the horizon. Let's go to our audience. We have a question on the right here.
Hello, Dr. Shuren and Dr. Tarver. Thank you again for spending some time with us today. Dr. Shuren, we greatly appreciate all that you've given to the industry and the collaboration. It's been outstanding, and I think we're all better off for it. And Dr. Tarver, looking forward to the same collaboration with you as you move forward in your leadership role at CDRH. My name is John Norp. I'm with Merit Medical here in Salt Lake. My question is actually for Dr. Tarver around the Home as Healthcare Hub. I've heard you mention that several times, and it really sounds fascinating and I think is visionary for all the reasons that you've mentioned. In the room, we have many from industry, primarily industry, who are wanting to know, and myself, what does it mean for industry? When the rubber starts to hit the road, what can we expect from FDA as you pursue this vision that you have?
Thank you for the question, and I hope I heard all of it. I was getting a little intermittent signal in the middle, but I think one of the things that we're hoping that this prototype will afford is the industry an environment, an idea lab to start conceptualizing based on a footprint for those who have the least amount of resources. So the prototype will be available. It'll be a tool that people can place their own devices there and try to make design changes that may, one, help fit within homes that may not have all the buzzes and whistles that homes that you may live in or I may live in, as well as also understand what are the different pain points for that development. So the prototype will be available on our website for anyone to use. We also are creating a mini lab in our own facilities for folks to visit. We're going to put all the resources up that helped us understand some of the challenges that people face when utilizing technologies at home so that we can help provide some information that can minimize what companies one by one will have to provide for themselves. The other thing is that we're saying that this is not the end. It's an iterative solution. It starts with diabetes as one condition because we know diabetes impacts many different organ systems. And it also is a huge burden in many parts of our country, particularly in rural communities and in communities with fewer resources. So if we can start thinking there and imagining there, figuring out ways that people don't have to manage 5 different devices or have 5 different touch points with the healthcare system to manage their one condition that has 5 different manifestations. Can we simplify that for folks and thereby lead to better healthcare outcomes? This is where we want people to imagine and create. As I mentioned early on, we don't think we're going to do this alone. And I think we've made that very clear. Even on our steering committee for this initiative, we have patient groups and provider groups and the MedTech and Consumer Tech Association, as well as architects. And we've gotten insights from furniture designers and others who understand that in order for devices to fit in the home, they've got to fit in the home. And the home has furniture, it has appliances, it has a lot of other components. And so we have found when people put the headset on and see kind of the homes of many people that live in this country, that it creates new ideas of where they could potentially design to tailor unmet needs and ways in which their current design may not work so well for some people that really need that technology. So it's the beginning of a conversation, I guess, to answer your question, and it will be available. We are finishing up the work for the prototype. It will be available early in the next year in 2025 or towards the end of this year. We're hoping to get it up and available.
Thank you. All right, another question. Please identify yourself and ask your question.
Hi, I'm Chris Phillips with Epitel. Happy to have you both with us today. I made the mistake last year of calling you Jeff, Dr. Shuren, so I'm not going to do that again. Jeff and Michelle, thank you both. I do have a prepared question. I wanted to ask, innovations in AI and ML hold immense promise to advance health, improve safety and effectiveness of current and future therapies, and bring care closer to the people who need it. Current frameworks may limit the speed at which these advances can take hold, sometimes for the positive and sometimes for the negative. How does CDRH intend to balance the potential speed of beneficial advances while maintaining a standard of safety and effectiveness?
Maybe I could, Jeff, if you want to tell the history, and then I can kind of pick up where we are going now, if you'd like.
Let's dive into where we're going.
All right.
This path.
Well, so I think, you brought up a really important point, which is AI/ML is proliferating everywhere. We're seeing it being used in many, many different devices, and it is a device We've got, 1,000 authorizations and counting in terms of the AIML space. There's a couple of different areas that we've kind of touched on that you probably have heard many from our centers speak about, which is the first is the data that is training those algorithms, the validation, and then the total life cycle management of AIML, because once it's deployed, is it continuing to perform as expected in the various communities in which it's used? And so we are thinking about that holistically. As you saw, the predetermined change control plan, AIML draft guidance that we put out, we're working on finalizing, understanding that these software changes happen rapidly and they're iterative, and we can plan for it so that people don't have to come to us each time to ask for any particular change. So that is moving forward. There's also been, you've heard us speak also about the importance of validation of the data that is used in the training and the development of the technology. And so creating some assurance around quality assurance around that data is a move that we have been encouraging within the entire ecosystem. So, and the importance of global harmonization has come up frequently. We are partnering with many of our international partners to come up with consistent message around good machine learning principles and practices, as well as ways in which we can collaborate and come up with similar approaches so that companies don't have to wonder, if I come into one country, what are going to be the rules in a different country? And that's also the impetus behind a lot of our international medical device regulatory forum activities, which is how can we create harmonization so expectations are clear as we move across the globe.
Thank you.
Jeff, anything you'd like to add?
Yeah, just fleshing out, because Michelle is spot on, in terms of where things are going. Depending upon the purpose of that AI, need to be paying attention to local verification and validation. We've seen with some of these AI, when they're trained on a data set that's intended to be representative of the whole population, some of those developers have run into challenges because either the data set may be fine for what they picked out, but it's not going to be sufficiently reflective of local practice, the local population, and local factors. Or there are challenges in the data itself, and that's why Michelle has talked about the importance of the training set, the validation set, that it really is reflective and keeping mind of the data collected, even if it's of that population. Was it collected properly? We've seen a lot of systemic biases incorporated into data sets. But increasingly, for things that are predictive, for example, we've noticed that changes in the population just a little bit, or in the clinical practice that goes on, or in operational characteristics in a local facility, can impact the performance of the AI such that it's not fit for purpose in some cases. And I'll throw out there an example with Epic, with their sepsis prediction model, wound up failing in a lot of local instances. And so the current thinking is, how do we equip, because we're not equipped today, local institutions to have a capability for being able to do that kind of periodic monitoring to make sure the technology is still fit for purpose for their local use. And that's something I think we're very interested in hearing what the community thinks about it, because everyone's trying to figure out what is the most efficient, effective way to do this, to assure we've got the right technology, but in a manner that actually can be implemented locally.
Thank you. All right, we have another question. Please identify yourself.
Hello, I'm Ronald Day, or Ron Day, and I'm a retired pediatric cardiologist. I just wanted to take this opportunity to thank the FDA for developing the Pediatric Device Consortia. I was able to get a small award with that, but so thanks for that. But I also wanted to hear what your plans are for the future of that. We have a lot of children in Utah, and I think it's a great opportunity for us to develop more devices for children.
So as you have already highlighted, we really do value and prioritize the development of medical products for children. We have been actively working for over a decade and helping to advance that work. And, the Pediatric Device Consortium is one area where we're seeing innovative technologies being developed that are specifically and at the outset targeted for children. And in fact, in order to help encourage some innovation in that space, our guidance document on breakthrough devices, we recently did an update last year that actually highlighted the importance of considering children as part of the health equity consideration around breakthrough device designation. So already acknowledging there's much work that needs to happen here. There's much that we would like to encourage in terms of innovation. But to your point, there's been a lot of challenges in getting devices on label for children. And some of our efforts in the past have focused on ways in which we could leverage data that already exists. But then how do we create partnerships across the entire ecosystem so that we can create an appetite for folks to innovate, understanding the commercialization aspects, the coverage aspects, the integration into care. And so we've been working with the FNIH, the foundation of the NIH and other NIH partners to help move that needle forward, as well as industry, patient, and provider organizations, as well as the PDCs have been a large part of that. So I think when we work together, we can help work on some solutions. But to your point, it really does require stimulating and creating centers of excellence that can really move that needle forward together. Rare disease is another space where we're seeing a lot of growth and opportunities for both in the diagnostic as well as in the therapeutic areas. And we are working as a center and collaboratively across the agency on those areas as well.
Thank you. Another question?
Good morning. My name is Spencer Walker. I'm with the Center for Medical Innovations as well as Peak Regulatory Consulting. Jeff, you mentioned how the FDA is really working a lot on innovating with industry and all the collaboration. I'd have to say I really was very happy during the COVID times. I was able to get an emergency use authorization through for it with a ventilator, and that collaboration was incredible. And if we could bring that into today's world, post-COVID, that would be amazing. We'd see products make it to the market much more quickly. That collaboration was one of the best things I've seen in a long time. Getting products to the market so quickly, yet not reducing the safety or effectiveness concerns or evidence that was provided to you. The question I have, though, is with all of the problems we are seeing in the EU with the MDR rollout, how can we be confident that the FDA, in their international collaborations that you mentioned, aren't going to move in that same direction, which in industry we have called the regulatory Armageddon?
Jeff, do you want to start with that one?
Sure. Well, I'll give you the bottom line, which is I can't say we anymore, CDRH works with a lot of different partners. At the end of the day, though, I give credit to the people of the center. They move forward to do the right thing. So they're not going to move forward to suddenly take on aspects of Europe if that doesn't make sense as the right thing to do under the authorities we have. On the flip side, I'm a strong believer, like Michelle, in the importance of collaboration. And I've seen over time how important it is to engage with our partners in other countries to try to assure that we have, if not fully harmonized, as converged approaches as possible, because it ultimately best serves people globally. It facilitates the access to important technologies that are safe and effective to a greater number of people, and it allows industry to be far more efficient and strategic in its resources as it innovates and tries to bring product to market.
Let's go to another question.
Good morning. My name is Anula Jayasuriya, and I'm an investor focusing on women's health, innovation, and very broadly defined. And in that context, I want to thank BioUtah for having a dedicated track on women's health today. I commend them for doing that. My question is about the new clinical trial guidelines, and I'm wondering whether we might expect to see the data that's collected in the clinical trials being analyzed by sex and gender going forward, and whether that would become an impetus for pharma to follow suit on that for the drugs to better suit women. Thank you.
Thank you. So we have, as you probably have seen in October, we took a very forward-leaning approach. We looked at some of the new authorizations that we've had for PMAs, and we had issued a new template for people to report in their labeling the clinical trial composition of the population that was studied under that particular submission, and we externalized it. So we created what we call diversity snapshots, device snapshots that show the composition, race, age, sex of the population and ethnicity of the population that participated in that clinical trial. And it was a way for us to show transparently who was actually participating in trials. And that is consistent with, I think, all of our product centers actually relay those for certain types of submissions. We also looked retrospectively at the submissions that have come in since we've issued guidance both for the sex specific reporting as well as race, ethnicity, and age reporting. And we looked at the data that we've collected in those same submissions. We are seeing that things are improving, but we've got a long way to go. And I think that's part of the impetus that has been behind the Diversity Action Plan draft guidance that issued in June. There is an effort to look for proactive ways in which people can bring folks to a trial that will look like the folks that you'd like to use those particular products on those devices. And so that work is still underway, but we are transparently sharing data on who was actually studied in the trials to support that marketing authorization, that marketing decision.
Step.
Okay, next question.
Hi, I'm Alden Brown, and I'm with Nusano, and we are bringing a 100% domestic supply of medical radioisotopes to the market beginning next year at our facility right here in Utah. And my question to you is, the FDA played a critical role in helping the U.S. achieve a sufficient supply of molybdenum-99, and how do you foresee the FDA continue to collaborate and facilitate in the development of next-generation radiotherapeutics?
So the supply chain efforts really were born out of the COVID-19 public health emergency, where we were, as a country, as a global environment, just totally stressed by the absence of certain medical products being available. And the supply chain program really was born out of that need to find solutions for those providers, those healthcare centers that needed access to critical medical devices. We've got a team of folks now that have helped and work collaboratively with other government agencies that are involved in the supply chain of various different components, whether they be semiconductors or isotopes or other components of medical devices. We work across the entire ecosystem to try to find solutions so that patients and providers don't have to do without. And so to the point that we have made, and I will emphasize, highlight, and underspold it, which is collaboration is critically important in order for that to work. Now, that being said, supply chain illumination and figuring out where there's challenges and predicting where there may be challenges takes a lot of effort, takes a lot of hands on deck, takes data, and takes a concerted effort of our team. We have been doing a lot since the public health emergency ended with people voluntarily telling us, but we often don't hear it from companies. We often hear it from the patients and providers once the supply chain has already been threatened. And so we are encouraging companies to really let us know early. We want to partner. We want to help. We want to find solutions so that patients and providers don't have to go without. The other thing that we are doing is we are listing on our website those critical medical devices so that folks understand the places where we really would want to hear early when there are challenges. And to the other challenge that we have is, for all things, we have resource challenges, but we've worked creatively and found solutions. However, with the resources that were invested during the public health emergency, it is going to become more and more challenging for us to meet the demands of addressing the supply chain challenges. And so we are working hard. We are committed to the mission of ensuring that people have what they need. But I will say that it does get more and more difficult as our resources become more challenged.
Okay, next question.
Hi, my name is John Skousen. I'm with Microport CRM. Really, over the last few years, I'm also a proud former employee of FDA, so I greatly appreciate my time working with both of you, actually. My question is, we've made great strides, and I think FDA has done a number of fantastic things that you've both highlighted and the other questioners on a number of fronts, from programs, guidances, investments in just review staff. And this question may be a little too early to answer yet, but with the change of administration and some of the signaling we're getting about just the government workforce in general and their plans for it, how can we protect, all the great strides that FDA has made in supporting industry and accelerating, things coming to market quickly? How can we protect that and also continue to improve with some of the things that are being talked about in the media and others?
So I'll say, we're focused on our mission. We're going to stay laser focused on our mission. And we, as an entire workforce, are continuing to look at how can we do our job better each day and making sure that we uphold public health. I think that's where our sights are laser focused on. I think as a team, our leadership team is committed to helping to move that forward, and we're looking at ways that we can create efficiencies in our business process within our walls. We want to make sure that our staff are empowered. It's one of our priorities, that our workforce is agile, adaptable, and can adjust to changing times. And so we're already kind of putting in place approaches that allow our staff to be creative and to work well and continue to, like I said, move forward with the mission. As you know, I don't want to speculate. I have no idea what tomorrow will look like, but I can say for today, we are continuing to do the same great work as a center that all of our staff are committed to continuing to do.
Okay, you've mentioned a few things, Jeff and Michelle, about international. I know in years past, international harmonization has been a real challenge because every government thinks they have to do it in their own way. Can you just give us a quick update on what is happening with harmonization with other countries, and where do we stand in that process?
Yeah. Well, let me kick this one off. Working with other countries in that drive towards harmonization, if not convergence, has been a high priority for the center for many years. And, we had envisioned and helped co-found the International Medical Device Regulators Forum. And when that started back in, actually first meeting was 2011 to start to try to get support behind it. And very first meeting in person was 2013. At that time, we started with 8 countries and regional harmonization organizations. Today, that has now just tipped over to 41. And there's representation from every single continent except Antarctica, because the penguins they're just pesky little critters. Very hard to get them on board. And things have changed. We just talked about it because the U.S. just chaired this year, and I was the chair for it. How we moved from having these very tentative, highly diplomatic, straight out of TV discussions, to where now these groups of countries and representatives talk about themselves as a family. And we've moved in directions where the thinking, even if the policies aren't there yet, the thinking is coming together. And in fact, for the US, when there are new areas we go into, like in AI, our thought is, let's not do it alone. Let's try to do it together with the international community. We're all struggling with the same issues. Let's try to build it together from the get-go. You've seen some of the things come out, like the medical device single audit program could not have occurred years before, but today we're all leveraging the same audits, inspections that are being conducted off the same ISO standard, which is having a big impact on efficiencies for both multinational companies and for, the regulators. And the big area you're going to see now moving forward is on reliance. All those circumstances and what can we do to get to the point where we can rely in whole and in part on the actions and decisions being made by another trusted country. That was a top priority this year out of IMDRF. And early next year, you're going to see coming out of the organization a playbook for how countries can go ahead and do that.
Great. Anything to add, Michelle?
I think, Jeff covered it well, the importance of partnering and harmonizing across countries. I mean, it is something you've seen in the AI space. We've done it in cybersecurity. There's a lot of different areas, and we will continue to build and do it in those and other areas. And then helping other evolving regulatory nations kind of come up to speed too, right? As they're learning and growing, we create this affiliate program that allows us to share those learnings across borders. Therefore, we can have predictability in many different arenas, and it will help encourage and replicate that reliance model that we're hoping to see continue to gain root and bloom.
All right, another question.
Thank you very much. My name is Alison O'Mahony. I'm at Seek Labs. Dr. Tarver, I really appreciated and applauded your commitment to a patient-centric approach as you move into your new tenure. I wanted to ask, in addition to, as innovators and developers, that was very motivating, but in addition to the relationship between patients and providers, there's a third P in that, and it's almost like the third rail, and that is the payer side of things. And there's an oversized influence on what medicines, what technologies, what devices a patient has access to because of their health insurance coverage. What role does the FDA have to influence access given your patient-centric mission?
I think that sentiment is part of the underpinnings of the TAP program, the Total Product Lifecycle Advisory Program, which really does look at we're one element of the entire healthcare ecosystem. You've mentioned patients, we've talked about providers and payers. All of that is important when a company is thinking about conceptualization of their product all the way through commercialization. And by understanding the evidentiary needs in each of those different communities, because all of them do require some evidence, but it may not be the same evidence. And so ensuring that those conversations happen early in development is a way to help de-risk the downstream commercialization process for a particular product. For example, patients may give you insights in terms of what the unmet need is if you're designing your device. It may also help you to tailor what the clinical trial might need to look like in order for it to be patient-friendly and more likely to retain patients throughout the duration of that study. Providers may give you insights into how whatever you're developing may fit into their current care paradigms and what may not fit or what may fit, or with certain changes, how it could fit better. And then the payers, they require different evidence. They may want to see certain things. They may want to see certain populations. So at the time you're developing your clinical trial, you can develop it to meet all those different evidentiary needs. That is the impetus behind TAP. Right, as you know, it was part of the Medical Device User Fee Amendment 5 commitment, and we started already with the pilot. We have 50 companies at the end of fiscal year 24 that were participating. Cardiovascular disease was one of cardiovascular areas, one of the OHTs that were involved. Neurological and psychiatric and physical medical rehabilitation is the second. We now have, as of October 1st, ophthalmic devices. We also have radiological devices, and in January, orthopedic devices will come online. So it is building to try to help facilitate these conversations so that people can generate the information that's needed for the communities that need it most.
All right, we're just about out of time, but let me ask another question that I know some people have here. Conventional wisdom when you're working with FDA is don't rock the boat. Don't press too hard. but sometimes the process does go off the rails. How do you recommend an aggrieved manufacturer address their concerns without offending reviewers and having some sort of retribution? Or how do you distinguish between a company that's just whining about not getting what they want and a legitimate complaint? And what is the best process to go about doing that if you feel like you're stuck in a review process and you can't get through?
So I'll start with what I'm going to encourage, and then Jeff can share what he's done historically. But we have, from my perspective, we've been very much an open door policy. I welcome emails. Let us know what's not going well. How do you improve if you don't hear from people about what's not working so well? And we have asked for that in various areas. Biocompatibility is one area we did hear from companies who said things aren't going so great. Is there a way that we can take a look at this particular area? And we are. That's the way that I think communication and transparency on both sides is very helpful in order for us to continue to improve. We're not perfect. I don't think we've ever espoused that as an organization. We're willing to learn too. And so I ask, if there is a concern that you think you've been knocking and you haven't gotten a response, by all means, we're willing to hear it. Reach out to us. There's also the opportunity to throw the flag, right? Also as part of the review process. So you can throw the flag, and it will also prompt a re-examination of the concerns that you raise. And I don't know, Jeff, if you want to add anything.
Yeah, no, that is the message, quite frankly. And you can start and try to work with the local team, but if that's not going in the right direction, make sure to elevate it. And if there's a time pressure, then elevate it, quickly. And as Michelle said, there are opportunities you can throw that red flag if it's in the midst of a review. We're both physicians, and at the end of the day, you can't take care of someone if they're not going to tell you what's wrong. So you got to tell us what's wrong, and that's not only beneficial for you; it's beneficial for us, because it's one of the ways we identify if is there a real problem? If it is it a one-off, or do we have something more systemic that we need to deal with? Or I should say that Michelle needs to deal with, because in about 26 hours, I get to shut down this computer forever.
So when you say throw the red flag or make your thoughts known, is there a proper channel to go through to do that when you say escalate? Escalate to the branch chief, escalate to the division. At what point do they go to one of you?
I think I obviously will encourage people to follow through escalation to the next level. And if you are hitting roadblock after roadblock, and it really is something that you think no one's listening, you can always escalate to myself. I'm happy to hear it. I'm happy to have a conversation. I may not have all the answers either at the time of the escalation, but I do think that collectively we can try to figure out a solution. And if we can't figure it out, we will look to see if we can, if it, like Jeff alluded to, if it's a systemic challenge, we're going to try to work on fixing that. And if it is the submission focus challenge, we'll work on addressing that as well. So knock on our door, tell us what's wrong. We do answer.
Well, thank you so much. I have a million other questions about Valid Act, about trying to get LDTs, about how we change our statutory framework to work in the 21st century, and we're not working with 1970s legislation. Unfortunately, we don't have time for all of those. But let us just say, Jeff and Michelle, thank you so much for your time. And Jeff, thank you so much for all that you have done. This has been a very valuable exchange. We appreciate the open dialogue with our summit audience. We know that you have a tough job to do, and we appreciate you taking the time to be with us. And Michelle, we hope to have you next year.